move on to our second panel. And today we're honored to have a contingent from our county's local health plan to give us an overview of the new populations of focus in Medi-Cal's CalAIM initiative. It's my great pleasure to introduce the moderator for this panel. Dr. Steve O'Brien is the Chief Medical Officer at Alameda Alliance for Health. He's an internal medicine physician who graduated from University of Washington Medical School and did residency training right across the bay at UCSF. He's provided HIV care in Oakland since 1995 as medical director of East Bay AIDS Center. And he joined Alameda Alliance in 2019 after serving as chief medical officer at Altabate Summit Medical Center. So Steve, welcome. Thank you very much for moderating the panel, and I'll hand the floor to you.
Thank you, Ms. Peterson, and welcome to your audience. What an exciting conference this has been. Really learning a lot from really excellent partners that we partner with on a regular basis. EBI spoke last, one of our key partners. I'm happy to be joined today by two of our subject matter experts at Alameda Alliance for Health. We're a health plan with 350,000 members in Alameda County, Medi-Cal, and a small group care line for some IHSS workers. And I'd like to introduce Dr. Amy Stevenson, who is our clinical manager of enhanced case management. And Dr. Stevenson is been with the Alliance for many years and is trained with extensive work in the background of case management. Dr. Stevenson.
Hi, everyone. Thanks for having me.
Also joining us is AJ Dixon. AJ Dixon is a nurse with extensive experience in the Bay Area. She was with Kaiser for many years and Brown and Toland for many years, and really knows the health systems very well and is an expert from our integrated planning department, helping us set up some of our programs for long-term care. Hi, AJ.
Good morning, everyone. Thank you for the opportunity.
Awesome. And if we could share the slides, that would be great. Awesome. Thank you, Ms. Peterson. Next slide, great. So we're here today just to give you some updates on CalAIM and the long-term care, enhanced case management, and community supports and how they're applicable to the discussion today. Next slide, please. CalAIM, which is California Advancing and Innovating Medi-Cal, is a really transformative process from this administration and from DHCS, trying to systematize, simplify, streamline, and enhance Medi-Cal across the whole state. Their main goals are focus on the whole person, really increase the focus on the social drivers of health, like you've been hearing this morning, also try to improve quality and improve equity, but there's a system transformation component to it in many ways, while making it consistent and seamless across the state. Next slide. There are key populations of focus as targets in this CalAIM initiative, and older Californians and people at risk for institutionalization are two of the key populations that have focus for CalAIM. Next slide. And then we're here today to talk about three areas in which there's been significant change in the last couple of months. One is in the area of community supports or in lieu of services. The other is in enhanced case management, a case management program that's new and new populations coming in. And finally, a big change in long-term care population, people in long-term care facilities, of which there's about 2,000 in Alameda County. Next slide. Dr. Amy Stevenson is our expert on enhanced care management and community supports. Next slide. Dr. Stevenson, can you tell the group a little bit about what is ECM?
Sure, great. Thank you, Dr. Bryan. Thank you, everyone. So ECM, or Enhanced Care Management, is, Dr. Bryan said, is part of Medi-Cal under the CalAIM initiative. So this benefit is for Medi-Cal members. So I will just give a disclaimer: if someone has Medi-Medi, if they're a Medicare and a Medi-Cal, under their Medi-Cal, they would also qualify for this program. And this is really basically community case management that is very, very intensive. The people are assigned to a group of specialty providers who we have in our network. These could be medical providers or community-based organizations who have specialty areas of practice like East Bay Innovations. And we partner with them and they become our ECM providers. And when someone is enrolled in ECM, they are eligible to receive what's called a lead care manager, a single point of contact. So if Amy is my lead care manager, for any problems that I have going on, I call Amy. It's Amy's job to coordinate all my care for all of the different providers and social services that I have going on. Because this is a whole person care program. And so part of that is that they outreach to and engage that member because it is an optional service. So the same members do need to consent to enroll. There's also a very, very detailed assessment and care plan. This assessment is looking at whole person care. So physical, mental health, dental, social services that they need. And to the point of the care planning, that care plan is meant to be patient-centered and patient-driven. We had some comments earlier from the panelists, right, that clinicians want to work on this, but it's not what the member wants to work on. That's the opposite of ECM. It should be what the member wants to work on. And then we start to work on some other stuff at this later on, right? It provides enhanced care coordination, health promotion, so teaching them about signs and symptoms and how to manage their conditions. Transitional care, so that very risky 30 days post-discharge from a facility where people often readmit back in if the right services and supports are not put into place. Member and family support, so this could be helping the family learn how to manage someone's conditions or putting in more support services that are needed. And finally, again, referring and coordinating to different support services, some of which may be within the Alliance, many are outside, could be social services or other groups and organizations that someone might be eligible for. As far as the specific populations of focus, this has been rolled out in several phases into the state. And so we currently have several populations that are eligible for ECM right now. And these are all adults, so anyone over 21 who is homeless, a high utilizer, so using the ED or inpatient facilities, someone who has serious mental illness or substance use disorder, and the newest ones that just became eligible last month were adults living in the community who are at risk of long-term institutionalization, and then folks who are living as a custodial resident in a skilled nursing facility who would be appropriate with the right services and supports to come back to the community and live back into the community. The ones that the yellow screens there, they're the future populations that are going to be coming out in the next 6 to 12 months.
Next slide. Oh, Dr. Stevenson, tell the group roughly how many people do we have in ECM, eligible for ECM and in ECM right now?
Yeah. Right now, we have around 12,000 members who are eligible for ECM. However, we only have about 1,000 members currently enrolled. So we're always trying to spread the word and get people referred in. And that's what we're going to talk about here next, is that we did provide to Wendy the ways to refer into this program. So we see it as a no wrong door, guys. So if you know of someone, so a member can refer themselves, a family member can call into the Alliance, a medical provider, if you're a community-based organization, if you're working with this member in some way and you might think that they could benefit from these types of services, please send over a referral to us. We'll assess and figure out which programs they qualify for and reach out to them and try to get them connected.
Can you also describe, Dr. Stevenson, what type of providers, ECM providers we have? Just get some examples of some of our ECM providers.
Certainly. So we have a large network of the federally qualified health centers. So some of you may be familiar with organizations such as Lifelong Medical Group. That's a large provider here in Alameda County. They are one of our providers as well. There's many other FQHC clinics. Alameda Health Systems. So Highland, Eastmont, Hayward, which you may be familiar with. We also have several large doctor practices. And then we have community-based organizations such as East Bay Innovations, BACS, who can work with homeless and serious mental illness folks. And we recently brought on the county, Alameda County Behavioral Health is actually one of our ECM providers as well. And we just brought on 2 new providers also to really help us with that at risk for long-term institutionalization folks so that we can really serve that population.
Awesome. Hey, and I know the ECM is a really important one of our case management programs, but as part of our case management portfolio, can you briefly describe, hit some of the highlights of some of the other case management that's also available for Alliance members?
Yeah, certainly. So this is to my point, guys, don't worry about which program they qualify for. Just send them over. We'll connect them. We'll figure it out. And the other, so if someone does not meet the qualifications for ECM, we have other programs that are available to our members. These are more telephonic programs, however, where ECM is meant to be more face-to-face in person. But we do have nurses and social workers and health navigators who can help support the members telephonically. We have our complex case management program, and that's for the people who need that really detailed, very intensive case management. We also have transitional care services. So again, just if someone's discharging from a hospital or skilled nursing facility for that 30 days post transition, we'll make sure that, they need those services, that they've been able to get that lab work and follow up on those medications. Also care coordination. So if somebody's just having trouble getting access or navigating the system in order to get an appointment or something scheduled. And finally, another one that's available is community adult-based services, or CBAS. This program actually is provided in the community, and this is for folks over 18 who are medically appropriate and need additional care and support throughout the day, but it also gives caregiver breaks for their family as well. So this is where they go to a center in the community for several hours a day, several days a week, where they have the supervision of a nurse, social worker, they have group activities, meals are provided, and transportation is provided to and from. So it's a really great way to help support someone to stay in the community and keep them engaged as well.
Awesome. Next slide, please. So the whole goal of, one of the goals of CalAIM is trying to help people stay in the community, and trying to address the social determinants, and really look at opening up the options through Medi-Cal, which is a regulated benefit, but to look for other benefits. And in lieu of services is what it's technically called by the legislation, but we call them community supports in California. Can you talk a little bit about what services we offer and what's coming down the pike real soon?
Sure. Yeah, great. So unlike ECM, as Dr. O'Brien mentioned, that's a benefit, and those other services we have, someone does not need to be in ECM in order to get community supports. This is open to all of our members as long as they qualify for one of the categories here. The first is a housing bundle. And we call that because that includes housing navigation, tenancy sustaining, and housing deposits. This is provided through the county housing services. We partner with them in order to help cover those costs and provide those services to help people find a home and stay in the home moving forward. We also offer medical respite. And so this is primarily for folks maybe who are homeless, who are admitted to the hospital or skilled nursing facility, where it's not really medically appropriate for them to stay there any longer, but also discharging them without some additional care would also not be appropriate, right? So this is where they can go and have additional supports for, a series of weeks after their discharge so that they can make sure they're stable. We have medical food. And so this, we can provide medically tailored meals or grocery boxes. There is an option also for non-perishable goods for homeless members. But this is not meant to address food insecurity, I have to say. It is meant for folks who have a medical condition. So this could be a new diagnosis, for example, of diabetes, or they might have recently discharged from a surgery, right? And might have difficulty being able to prepare food for a couple of weeks after discharge. We have asthma remediation. Currently, this is for our pediatric population, but we are looking to expand that in the future to include adults to help. This would be home remediation to help with things like mold abatement, HEPA-vax, things like that to prevent asthma triggers. And finally, we're in a pilot phase right now for 2 of these programs, which is, we're calling that short to get out of long-term care and stay out of long-term care. One, so as we mentioned, there's those ECM populations that are now eligible, right? The staying out of the skilled nursing facility and transitioning out. Well, as you can imagine, there's going to be a lot of services and supports that need to be put in place in order to do those things. So both of these are looking at things like potentially helping them also find housing or modifying a unit, in order for them to come back or stay in that community. And so we are in a pilot phase right now for that as we assess this, because long-term care, as AJ is going to talk about, is brand new to us at the Alliance. So we're taking an approach and learning from our great partners such as EBI, who've been doing this great work for so long. And finally, in the future, coming in July, we're going to be having some new as well expansions into our community supports. One is personal caregiver services. And so this would be in supplement to IHSS hours, because we know sometimes it takes a while to get someone set up on IHSS, or maybe IHSS is not quite enough for what the person needs. There'll be home modifications. So this could be, again, to help someone stay in the community, right? Adding grab bars, ramps to the house, those types of things, some minor home modifications. Caregiver respite. This is different than the medical respite. This is truly for the caregivers, right? So they can get a break, so that they maybe have to have, a medical procedure themselves and need a break. And so we would provide extra care in order to provide that caregiver respite. And finally, sobering centers. In order for folks to be able to go to a sobering center instead of inappropriately going to the ED or the jail.
Awesome. Yeah, I have to say, as a 30-year provider in Alameda County, it's so exciting to see these services come. I know that these have been issues for a long time, and now more than ever, as real barriers to people being able to have good, successful lives, happy lives. So to be able to see them supported within limitations, remember, everything comes through regulations, and so there's limitations on it, but to see them start to come, and we're excited about it as a plan to start to offer them. We're starting because we're just learning as we're getting into these various things, like personal caregiver services, all the agencies that provide those, and contracting with those. Each of these is a venture unto itself, but we're excited over the next multiple years to continue to build these out. Hey, Amy, before we turn to AJ, we had a couple of questions for you. One is related to ECM and complex case management. Are they both home visiting?
No, only ECM could be home visiting, because they do have community health workers who go out and meet with the folks either in their homes, if that's appropriate for them, or even at a skilled nursing facility. However, our complex case management is all telephonic. Okay,
awesome. And I put in a plug for saying, like, hey, we'll take some referrals for medically tailored meals, because I think they're underutilized. And then they rightfully said, how do we refer? How do people refer into these community supports?
Yeah, great question. I've also provided the referral forms to Wendy for the programs that you can refer into. For medical respite, I will say that's usually coming, and the housing are coming from those providers. So if you feel someone needs housing assistance, the proper place is through 211 or one of the entry systems to be assessed, because the county has to do their process before they send it to us. Also for the medical respite, that's typically done by a medical provider, like at a hospital, because they know if this person is inappropriate, or it could be a street outreach team who has seen this patient and determined that it would be medically appropriate to send them for that. But for the asthma and for the medically tailored food, we have those referral forms that we provided to Wendy to send out to the group.
Awesome. Last question. Do we offer long-term care, a long-term case management for members, or is it episodic?
Well, more of our telephonic program tends to be more episodic. For ECM, I would say the average time to stay in is kind of around 9 to 12 months. It is not perpetual. State does not say there has to be an official end date, but somebody has to need that level of care and justify it to stay at that level, and not at a lower level of case management that might be able to support them. So for ECM, they are given a much longer period of time to get those connections put in place, and hopefully either through themselves or with the support of family and friends being able to help navigate the system.
Awesome. Thank you, Dr. Stevenson. Next slide, please. In addition to developing programs to try and help people stay out of institutions and support people in their homes, we also inherited people in long-term care facilities. So up until this January, people in Alameda County who were in long-term care were in fee-for-service Medi-Cal. And there's about 2,000 people in Alameda County, and those people transitioned into the managed care plans January 1st. Next slide. AJ Dixon, thank you for joining us. How are you?
I'm well, sir. Thank you.
Awesome. Can you tell us a little bit about the transition that occurred and another transition that's coming up? What that means for us and people in Alameda County, these 2,000 souls living in these long-term care facilities?
Absolutely. Thank you so much, Dr. Bryan. So yes, as part of the CalAIM transformative framework or roadmap, we implemented the carve-in of the long-term care per subset of population into Alameda Alliance for Health. And there were approximately about 2,000 members that were initially formerly in a fee-for-service world and now are in our managed Medi-Cal world. Again, there are two phases in the subset of this population. The first one is the long-term care custodial patients. And then upcoming on the 2024, January 1st, 2024, we're also going to carve in another subset of patient population, which are the intermediate care facilities, the ICFDDs and nursing and habilitative, the pediatric and adult subacute custodial level of care, and also the patients that are currently housed in the Institutes of Mental Diseases.
Awesome. Now, as you might well know, each of these worlds is a whole world of institutions, organizations, the members that live in these facilities, and then their related services. Next slide. Can you talk to a little bit, AJ, about how we kind of our initial goals and our kind of how we're future thinking about these populations of people?
Absolutely. So essentially, the critical goal that we wanted to accomplish in transitioning these members is to have that seamless transition, both from a care perspective and from a supportive perspective. And the way that's been accomplished is through implementing continuity of care, not only for the facilities services, but also for any medical supply services, specialty services, and in any medication that those members are currently receiving in a custodial level of setting. We're also starting to monitor the transitional care services, as Amy mentioned earlier. That is key to making sure that people are successful in the current settings that they're in, and there is no setback or readmissions as they transition from one continuum to another. One of the ways that we facilitated this transition is to get to know the facilities that these members are currently living in. One of the venues that we put together are town hall meetings to get to know the facilities and for the facilities to get to know us and understand that we have a common goal of making sure that the transitions and the benefits and the care for this member is very seamless and there are no gaps. The other thing also that we wanted to do is to provide them with resources such as program guides and any sort of collaterals or documents that will help them communicate with us. One of the biggest things that we did in this transition is we actually put together a long-term care department in Alameda Alliance to make sure that there is a single point of contact, not only for the members that are currently living as custodial members, but also for this new network of providers and facilities that are now we're collaborating with us in taking care of these members. Again, the upcoming facility members are the ICF facilities, and we are already starting to get to know those facilities. We are actively participating in the DHCS webinars, where a lot of the facilities and the organizations that represent these facilities and advocacy are in that webinar sessions also, and we hope to continue to participate in those webinars. In the near future goals, what we would like to do is really enhance the quality of care for the members that are currently in the custodial setting. And the way that we want to do that is to really start monitoring the care and the services that is provided in this long-term care setting. We have increased in our quality programs and to make sure that there is a single point of contact for these members and their representative to contact us for any care concerns that is happening in the long-term care setting. We want to expand the available services that are in the long-term care setting again by incorporating the programs that we have in place in our health plan right now and any services and benefits that is inherently available to our members. We want to again reiterate that we are starting the program in pilot in identifying members for the subset of population, which is members that are at risk for institutionalization. And we're identifying that from the front end, mostly members that are getting admitted in the hospital setting, and how do we avoid them from landing in a custodial setting. And then, as Amy also mentioned, and Saron mentioned, that we are in a pilot with EBI in making sure that we identify patients that have the ability to transition back to the ability, and the transition is successful and seamless. Again, we're engaging additional community partners in the long-term care, the regional center of the East Bay, enhancing our CVAS program. We're also tapping into additional LTSS services, and also growing our community-based organization to provide additional services, as Amy mentioned, with the ECM and CS. One of the particular focus that we are also having is the upcoming dual patient population that will be getting carved in our health plan. And we want to make sure that we are enhancing the coordination of benefits and that seamless transition also for this subset of patient population.
Awesome. Thanks, AJ. Also, Alameda Alliance will become a DSNP Medicare plan in 2026. So we'll be able to, for patients who choose to, at that time, have their Medicare also managed under managed care. That will be an option for people also. I really look at this book of business as one that we're going to continue to grow over many years, because there's so many layers of the onion on both sides of the people in the institutions who need support and access to all the services that everybody else who's not in those institutions has, as well as strong support to help get people out and to stay out of the institutions when able. So we're very excited about that transition. I know we're getting short on time. Let me just see if there's, I know there's some comments about getting people out is very dependent on finding spaces for people to go. And from an economic standpoint, that's very challenging. Highly acknowledge that. The community supports that are currently available, there's others that are in discussion. Again, they come from the Sacramento as rules, including rent support as a possibility. That's not yet approved because it's Medi-Cal, it's for insurance, but those are things like that that people are continuing to look at. Great. I think we're at our time. And so with that, I'm going to hand it back to Ms. Peterson. And thank you so much. We're excited to continue to partner with the Senior Services Coalition at Alameda Alliance for Health. Thank you.
Thank you. Thank you so much, Dr. O'Brien. Thank you to your panelists and to Alameda Alliance for Health. There are many awesome questions in the chat. I want to let everybody know that in the chat there's a link to our conference webpage, and the referral forms that Amy mentioned are on that page. We'll be sending out and adding to the page referral forms for Anthem as well, and we'll be going through all of your questions in the chat and making sure that we address them in the conference proceedings. So thank you so much. Round of applause, virtual round of applause for Dr. O'Brien and the Alliance